the honest answer why I'm here, I think it goes back to around 2007, to my hometown, Haapsalu, a group of young, active, impulsive men, late teens, starting experimenting with drugs, getting, trying to figure out themselves. And I saw this around my friends, why are they, using drugs? Why am I not using drugs? Like, what's the difference? And like, it was such a captivating thing for me, and trying to figure out what is wrong with me or what is wrong with them. And this, I think, was the game changer for me that got me interested in what's happening in the world. Why people do this? Why some of my friends developed some problems. Some of them now, looking back, some of them went to jail. A lot of them stopped using. Some of them went to jail. One of my friends, unfortunately, almost 10 years ago, took his own life. So there's a lot of things that comes from my background in that sense. And this has kept me 10 years in the field of this topic.
So we are happy to hear you here, and please take the floor.
Thank you. It's weird being on this stage. It's like I feel like I would want to be lower. But I think it's okay. I will. Previous presentations were so interesting, so educational, so much science, so much things to learn from. I hoped when I was preparing for this presentation, the lessons learned from being the top country on overdose deaths. I hope to give more lessons, but I was making the slides and writing the notes, and then I realized like there are not too many lessons to be learned. It's rather than like a story throughout the years that maybe some of you can learn from or make, I don't know, realizations that we didn't make or I haven't made yet. So it's rather than like a history lesson. So, and as it is a late afternoon, and I try to not keep it too boring, and should be a little bit. Second. That's better. So. Yeah, I work in the Ministry of Interior. I have a public health background, so I'm kind of like an agent inside the Ministry of Interior, which is the police ministry in Estonia. But I do have a public health background, so I do focus a lot more on prevention and public health aspects of drug policy. And been the national drug coordinator for a little bit less than 10 years. And let's get into it. So this is an article from 2019. Have you read it? Have you seen it? Maybe it's familiar for you. How is Estonia the drug overdose capital of Europe? Well, actually, I think one of the even the correct answer would be how is it the drug capital or drug overdose capital of the world? As you can see in the charts here, we were going really high upon the overdose-related deaths, and it's Sweden, second place. We've been with the upper runner in this area. So, and I will tell you the story and the different aspects of it, how we became it. So this is like a chart with a lot of colors, but it is. I think it's good to put things into perspective. Estonia is such a small country. Sweden is a lot bigger. North America is even bigger, even more bigger. So if you look at the causes of death amongst people with HIV. We see a trend of the blue part, one of the biggest parts, being not the blue part, the orange part, being one of the main reasons for death among those people. So if you look at the other reasons, the overdoses contribute so much into young people dying for overdose, and also another one. And I think this is first indications on what is the reason behind it. So it's also the scale, the blue line here going and showing the number of deaths per year, with the bottom line showing the confiscated drugs from the market, confiscated opioids from the market. And as you can see, there is no heroin there. And in those cases that we have the data from, it's all fentanyls. So fentanyls, which is now the lead cause of death in the US, was in Estonia already years and years ago. So we've been dealing with those very dangerous drugs for a long time. So the next 3 slides will be the most text-heavy slides. So try to, not fall asleep reading the text. But I really liked my colleagues really put together a really nice historical background of the fentanyl emergence in Estonia. And then if you're interested in reading more about it, the sources are all down there. So basically, what we saw that the demographics of the fentanyl epidemic was like basically 3 steps, and it's based on Andrew Gollup's model, and it can be adapted to with many different opioid epidemics in the world. So just briefly go through it so you get the context of how things happened or came to be in Estonia. So the incubation area and the expansion era in Estonia started in around 2000s. So this is the time where fentanyl was coming to the market, heroin left the market, and within a year or so, fentanyl completely replaced heroin on the market. It's hypothesized that the market change was like almost directly as a result of the Afghan war and the poppy production went down, and that kind of left an opening spot for a new producer. So in our cases it was fentanyl. For Finland it was buprenorphine. But in a lot of countries, heroin kind of came back after a while. In Estonia, fentanyl was such a good product for the users. In a very bad thing to say it, but it was much more effective, so it kind of stayed. And we can see the purity also going down in the heroin. So after a few years, we saw that what happened was people didn't know what they were, getting. There was no product packaging. This is fentanyl, 3-methylfentanyl. This is the purity. So we saw that there's people who were kind of, naive, or I don't know. It's not a good word to say fentanyl naive, but they didn't know what they were getting. So it led to a very high surge of overdoses in a very short period of time. So fentanyl being 100 times stronger than heroin, in some derivatives it can be even, 1,000 times stronger than heroin. It was a big effect on people's health, including related in overdoses. So as it is kind of different effect, it is still an opioid, but fentanyls have a shorter effect period. It is more potent, but it has a shorter effect period, so you need to consume it more times per day if you want to have an effect. Heroin has a longer effect on your body, so it meant more times you needed to inject it per day. And as the population that was using drugs by then was a kind of a demographic that was the era of post-Soviet Estonia, of men not having jobs, or men having left out of the system, or kind of left out of the focus. Sometimes Russian speaking, sometimes just in areas that the Soviet Union's factories were working, so didn't have a job, didn't have an education, they didn't adapt. So this was very easy target to change from alcohol use or to opiate use, and this kind of this cohort has been most affected. Even now, we can see that these are the men born in the end of 70s and 80s. So, yeah, in their teenage years. So in the third phase, and what we can now say, the fentanyl has left the market. In 2017, the fentanyl, two of the fentanyl laboratories in Estonia were discovered, and they were dismantled, and people responsible in producing fentanyl were prosecuted, and this kind of what happened is fentanyl it stopped coming to Estonia. So it was a big case for the police and the prosecutors. So, and this ended up with people who were using the drugs reacting in a different way. So I will talk about a little bit more about when I come back to this. But we saw that people wanted to get new drugs because there was still demand, but fentanyls weren't available. So some of them started using other drugs like amphetamine type stimulants. Some started mixing drugs to get a better effect comparable to fentanyl. Some started to going to Latvia to bring fentanyls from there. Some started to order fentanyl. Some started to using catinones or bath salts or whatever these are called in popular word. So, but even in the cases where people were finding out new ways to get their high to fix their demand, the rise of the people who use drugs didn't happen. So the population who are starting to use opioids is going down still in that period of time. So anyways, I don't know if there's a third part to this or fourth part to this. Phases, which I named the coming of nitazines, which is what is happening now, and I will come back to this. So now less for the model, and this is kind of our perspective, what we have seen, putting it into more steps and just bringing in what was happening on the policy level and how we reacted, because what you just heard, these three slides was kind of happening on the user level. So, anyways, I tried to put them these steps, and I figured out it's 6 steps is kind of figuratively enough. So in the 90s, we were kind of ignoring that we have the problem. Drugs were kind of ignored. We were focusing on other things, building up a new country since the Soviet Union collapse. A lot of people were homeless and jobless, so drugs wasn't the big thing. Of course, HIV came at some point and put us like on the map, because HIV was very prevalent in people who use drugs, and this brought us to emerge like this kind of reaction, and this put this on the focus of drugs as well. Oh, sorry, never mind. I'll show this later. So yeah, so in 2001, when we saw that a lot of, we realized the HIV is kind of coming into general population as well. It's not only a thing that is happening in drug user communities, so it can come to for general population as well. So this kind of resulted into focusing on drugs, but not in enough way. So this emergence of fentanyls into the beginning of 2000s resulted in several waves of new type of fentanyls, like in 2004 and 2007, 2012, and again later with new stronger types of fentanyls. So just to kind of close the overdose and put this on a map, but I could have showed it the other way around as well. So this is again the chart of the overdoses. And what I mean by panic and reaction. So ignoring in the 2000s beginnings, the deaths started to rise, reaching 105 deaths per year. And to put this all in perspective, in 2070, when the article of The Economist was mostly talking about being us on the top of the charts, 2070 deaths with a population of 1.3 million of Estonians is around 193 deaths per million of 15 to 64-year-olds age group. Currently, I checked in the last year, I think in the US, the death rate for fentanyl deaths was among the same age group was around 220. So not a big difference. And the US is in a really bad spot right now. So you can imagine what 170 means for us. You know, it's not 100,000 like in the US, but still with the population that we have, very high number. So it's very nicely visible from the chart as well, how things happened and changed throughout the years. So this, the first waves and panics and reactions kind of resulted in deaths dropping and then going up again, because there was, you know, a lot of effort put by the police to catch the dealers and trying to get the stuff off the market. And you know, as you can see, it didn't work for a very long time. It was still a huge demand, so it kept rising. And eventually, you can see there's a success and question mark. In 2017, we kind of had a success for a few years when the death rates dropped through the end of fentanyl era, and we can see like the lowest numbers since 2000 that we had. And then there's kind of this acceptance that it's coming back again. But I will talk more about it, what is happening. So I didn't have these fancy slides that can, you know, appear out of nowhere, so everything is coming up at one point. So let's try to read from right to left, or left to right. So during what was happening on the policy level, as I mentioned, in 2001, the HIV epidemic brought the focus on drugs. We realized, you know, drug use and possession need to be decriminalized. You know, we cannot put everyone to jail. We need to have a health-focused approach. And fentanyl at the same time coming to the market. We had our first actual strategy. There was some kind of strategy in the 90s, but I wouldn't call it a strategy. It was just a few pages. So, national strategy for drug prevention in 2004 until 2012. And then another strategy in 2014, after final evaluation time, realized that, oh, we still have a problematic situation. We need to set more targets. We need to set more focus, more activities. There was a huge priority amongst the politicians. And there's another white paper was written. This is the time, around that time, I was started to work in the ministry. So, at 2017, the fentanyl market collapsed, and in few years after that, we now had nitazines. Do you know what nitazines are? I think it's been talked about a lot, but it's a new type of synthetic opioids, which is horrible. So anyways, in 2021, we wrote another drug policy. We did a very thorough evaluation, and we tried to learn from other countries and our mistakes, and we did write another one. And I will a little bit introduce it in the end as well, so you just get an understanding of if we actually did learn anything or not, so you can decide. So coming back to what's happening on fentanyls, and what happened after fentanyls was after fentanyls dropped from the market, then things got worse. I think it's the title of this article is maybe a bit populist, but I don't know if it got worse, but it did get worse in a few years, as you saw. So, then looking back again to this. So what went wrong? We have now nitazines on the market. Our opioid-related deaths have gone up double since 2021. We are back reaching the higher numbers, not the highest anymore, but almost reaching the hundreds again. So I tried to write down the things that might have been one of the things that maybe you can learn from, or that we realized that was not enough. So, for instance, in the 90s, so there was no proper investment in prevention, early detection, and even addiction care. There were some services available, but not nationally funded. They were not available. The reach of these programs was not sufficient at all. So this was one of the core elements. As you know, the Portuguese decriminalization model, I think, is very highly talked about all the time in different conferences, and it's been researched a lot. You know, Portugal decriminalized drug use and possession for personal use also around the same time that we did, in 2001 and 2, between there, like when it came into effect. So, but the difference was, like, Portugal, they knew that they needed to invest before into the services, into the system of helping people getting to the services, having these collaborations in sport, having prevention systems, stuff like this. We didn't do that. I don't know why, but we didn't do it. This was a long time ago. So the panic time in 2001 and 2, I think one of the wrongdoing was, like, focusing too much on supply reduction. Going after the dealers, even the users still, it was decriminalized, but, you know, still having a bunch of fentanyl with you would mean it was a high amount, so it would still be a criminal offense and could go to jail for. And, you know, focusing too much on this took away our focus and resources from having actual services and prevention in place. So we still didn't focus too much on it. By that time, we did have more and more services also built up. I think we did have the opioid substitution available at that time already, and we did have needle exchange services also building up. And during the second wave, when we saw that there's a rise again, I think it was because we lost focus in a way. So we kind of, you know, the focus was somewhere else. We were joining the European Union, and I think this is, you know, setting, you know, ambitions on a different place. But we didn't also have proper systems for early warnings. So if new drugs came to the market, we didn't have systems in place to change information among each other to know what is the, you know, result in that. How should we react? And, you know, as a realization, we still don't have proper systems in place. We have better systems, but, you know, I will come to that. So in 2007, 12, when there was new emergencies, I think there's still a lot of things that weren't dealt with, like the problem being stigmatized, people not seeking help, people avoiding police, people avoiding going to talk to their doctor about it. There was no take-home naloxone, which we now have, and there's significant help in that. So there was a big rise in overdose deaths, and this is how we got to the plateau of the highest numbers we had. And still, I don't know if these plateaus helped us get more funding, get more focus on it, or we could have done it without having the highest numbers in the world. I hope to say that we could have, but this kind of little bit helped us, you know, put this in the perspective. So, yeah. In 2017, I think we also lost focus, and we realized that services are there. We're doing a lot more harm reduction. We have take-home naloxone. We're trying to build new services, increase the quality, but we realized that, you know, there were still some barriers, like not in my backyard, this NIMBY, probably heard this. So people like said, yeah, we could have more service, and we can, you know, not put drug users in jail or punish them. So general population understanding of the issue started to change, but still not enough to actually have a really fast change. So in 2017, when the fentanyl market collapsed, so we were waiting like, oh, now everyone who were using drugs, they will come to the services because, you know, they have no drugs. They will come to get methadone. They will, you know, come register themselves for treatment. They will search for help. Reality was it didn't happen. They were starting to use, find new drugs to use. So we kind of were waiting for them to come to us rather than, doing everything that we can to go and find them and, use this moment of silence. So we did have the wrong expectations there. And we weren't ready for that. It was a kind of a surprise, I guess, for even the police and the prosecutors that, fentanyl market kind of totally collapsed and it didn't come back in a few months. So because we have had, caught criminals before and fentanyl still kept coming back. And nowadays, I think the biggest problems are we don't talk about it enough. The politicians don't, and decision makers don't want to talk about it. It's still like an issue that is so controversial in so many levels. Like, should we have safe consumption rooms or not? Then we don't want to talk about it because it might still upset some of the people, but it might help others. And Estonia being very small, I think the problem is we don't have enough people. As I don't know, one of the presenters was talking from one person in a local government on prevention, it started up to be a team of 12 people. It's never going to happen in Estonia. And I feel this is, there's local governments where there is only 12 people working in total. So it's still very hard to get the number of people trained and working in the field. And drug policy is still kind of a separate area compared to other health problems, like, for instance, violence or other health issues. So yeah, still it's kind of a different world, a separate world. Just upon this table, I think it really nicely shows how what services started to come to this to our package. So in what year around? So you can see it's going better and better, and especially with naloxone coming in 2013, it I think has helped us really much that we have more people and more services being provided. So I talked what we did wrong. So did we do something right? I don't know. This is like purely my opinion. This is not a scientific paper. This is what I think we did right. So throughout those years, there was always, as a small country, we have a saying that if you want to change something, you can just go and talk with everyone involved. It's so easy. We know each other pretty well, I think, and we managed to maintain cooperation amongst the police, the health service providers, with NGOs, with other partners in this field throughout those years. Somewhat cooperation. I think the second part, convincing the police. I don't know how it's in the other countries, how it's in Sweden, but in Estonia, the police and border guard board is one of the most trustworthy public organizations. If you put all the organizations and then ask if you trust people working there, police is one of the top of the institutions. So talking with the police and changing their opinions on the matter, and getting them to talk with people for us, for the health people, because it's always when someone from the National Institute of Health goes to a local government, starts talking about, we need to have more services, we need more prevention. It's just again the soft topics coming, and we have to deal with the real things. I don't know how it's with you, but still. It was a case in Estonia. So if we got the police on the same boat as the others, as the things and using the words we want people to use when they talk about drug issues, police was the key. I think still is. Even advocating for prevention, they do it really well. Any police officers here? No? Oh, where's the police? Why didn't you invite the police here? Yeah. Oh, there's one at least. Thanks. I felt like, what? Didn't you get the invitation? So investing in services and harm reduction and naloxone, like as I mentioned, last year we had 79 deaths of opioids and overdoses, which is double the previous year. I think it could have been triple than previous year if we didn't have the common naloxone. Like I could imagine that the number of deaths could have gone even near the 170, which we had the highest in these 2 decades, because we saw a lot of naloxone being used this last year. Usually, I think I think the naloxone, take-home naloxone, which was used last year compared to the previous year, was 3 times higher. So it meant a lot of people felt the need or had overdose and didn't die because of it. So it was 3 times higher use of the naloxone, but the numbers of deaths were 2 times higher. So it's a big effect on that. So I hope we saved a lot of people because of the services and the naloxone. And I think this second and third point, I think was one of the key elements also to put together. The police as a reference point for people to get help in the services. So in Estonia nowadays we have like several projects going on where when someone comes into the interest of the police who is using drugs or has some problems related to that, the police has a lot of ways to connect them to a service that can actually help, and they don't have to get punished. So I think it was one of the key things that connecting those things, those worlds. This cooperation with Lunest, I just brought out one of the NGOs that we mostly work with. There's several other NGOs that are doing very good job on with us. Cooperation with us. Lunest is the organization representing the people who use drugs. So getting their voice out there, bringing out the examples of people who are using drugs, who have used drugs, understanding what are their needs, what are their resources, really helpful. What are their resources, like for instance, early warning systems, like what information they have, and if they can be also those who are expanding the information. And the last point, prevention, evidence-based prevention. We have been doing a lot of wrong things with prevention. We've had, drug sniffing dogs in schools, ex-drug users explaining things to kids. We have done this in the past. We have done all the things that are now proven, not effective, trying to fix the problem that is, so hard for us. And I think around 10 years ago, we started really investing in evidence-based prevention, bringing in some programs from US, for instance, from other Europe, like Good Behaviour Game, Incredible Years, developing some programs and evaluating them ourselves. Really, really game changer. Not only reaching the target group, but also changing the mindset of people working in prevention, just making them understand what tools are available. Really, really big thing. So yeah, coming back to this, where we are now. So yeah, this is TAI is our National Institute for Health Development. Yeah, so we did, even having all those things in place now, learning from the past, even having adopted by that time our new drug strategy, we still have surprises, let's say, bad surprises ahead of us. So we cannot never, rest. And coming what we are planning or what we are focusing on the next, I don't know, it's a few years. This is our current white paper since few years. So one of the things, I lied, there's one more text-heavy page. So one of the things that we realize stigma and attitudes have a huge effect on changing people's behavior, changing people's access to treatment, the quality of it, even the NIMBY attitude, stuff like this. So we agreed that we need to have agreed upon ourselves and try to get this, agreements out to the whole population. That how we, what is our attitudes towards people who use drugs? What language do we use? Do we say an addict, or do we see a person who uses drugs? Can make a huge difference. And also how we work. We might, when it comes to prevention, we might take the easy choice and give a lecture in school, then saying, this is drugs, this is how they affect you, and they are bad, But we can, do something extra and actually maybe implement the school policy, as we heard from a previous presenter here. We were in this parallel session that you can do a lot more in the schools than just talk about how drugs affect you. So you can change the whole school's policy on it, and it has such a great effect. So yeah, we did have like this part of the kind of focus objectives. So we chose 5 instead of I think we had in the last strategy we had like around 10 primary objectives. So I think the most important to this presentation is the one in the middle. So we were having discussion and trying to figure out what when it comes to harms, what is our ambition, what we want to achieve by 2030, how like what is objective, and then when we were conducting this, we still had like 27 deaths compared to 79 last year. And we were talking about it and we realized like we cannot put a number to that. We cannot say like, okay, 5 people dying per year is okay. This is what we can accept. No, there is no accepting this. We have to go for that nobody dies for it. So this is one of the process we had, just changing our own attitude as well, or raising our ambition in parts that should be ambitious. But we also had 3 goals for each objective. I'm not going to go read it. You can, read it yourself. The strategy is in English as well, if you want to read the whole one. But there was a lot of things, and I think this lower part shows that we have a lot of things still that we need to figure out. So these are written as a question. So how do we do something? And there's a reason, because the world is changing around us so fast. The market is changing. The patterns of the users are changing. Our resources are changing. Our politicians are changing. If we have an answer, write down an answer in our policy right now. It can be irrelevant or unuseful next year, as we saw it with fentanyls. So there's also a few actions. I'm not going to go through it, so you can read it. And coming to the final slide. So what did we learn? So the first one, I think you can understand it. It's not going to go anywhere. There will always be some kind of drug use in the world. There are going to be still some problems related to it, and we need to understand it. It's impossible to get to a point where nobody's using drugs, nobody has any problems. This has to be adopted to all the policies we understand, at least in Estonia. So, and we need to still be very sufficient in changing our, ways. This is the second point. Policy is nothing something you write down in a paper and it starts happening. We need to focus on the implementation. It's not going to happen if we write it as an agreement that we now don't call anyone addict. We need to work for it. We need to do things for it. We need to advocate for it. We need to change people's, we need to react. So the solutions sometimes seem very simple. A colleague of mine loves to say it like, those things effective in drug policy are not popular, and those things that are not effective are popular. So sometimes it seems such a good thing to do, go back to schools with drug sniffing dogs. But this is not the solution. We know it needs to be a much thorough intervention. Evidence-based solutions, we have so much science. We need to translate it into actions. This is the challenge we're here for, probably, most likely as well. This is something we need to work with in Estonia still, but we're getting there. But as soon as we started, having more science translated to Estonian, more publications given out, more conferences, more talking about with the politicians, we started to understand also that their opinions can be changed. And this open communication, we still need to engage with parents who are worried about their children vaping in schools or finding cannabis, or heads of school or headmasters coming to the police and saying, come back to the school and do something because there's a problem with this. We still need to communicate what we are doing because we sometimes forget to talk about. Estonians are very shy in that sense. We don't like to promote ourselves, what we're doing, like if we do something wrong, then of course, but if we do something good, we are not, able to talk about it. It seems like a egoistic thing to do. But sometimes we do need to talk about it, and we need to talk about it with a lot of people, as we are doing it here. Thank you.
Thank you, Ain, for this, and I do believe that there will be questions. Do we have anyone? No, but there must be in the audience. Berta, yes, thank you. Can you run?
But you can take this one. There's two.
Oh, you have.
No, but you, yeah, you.
Yeah, we can use one.
Yeah.
We can use one.
Thank you. I'm very curious about Estonia being a unique country in terms of the fentanyl epidemic that you saw starting in the 2000s. Clearly, the heroin loss was throughout to Europe. Why fentanyl in Estonia, not other European countries? Other European countries had a heroin problem as well. So I don't understand that gap in my knowledge.
That's a really good question, and we've been asking ourselves that as well. There's several tries of explaining this. When you go to some of the restaurants, there's Coca-Cola on the menu, and with some of the restaurants there's Pepsi, but never both together. You realize that? I think it's a similar situation when it comes to drug market. If there is an organized crime group or a supplier working in a country, it's just them mostly in that subgroup. I think proximity to Russia, having Russian-speaking people involved in the crimes or bringing the fentanyl in that we caught in 2017. This kind of showed us also that proximity to our eastern neighbor kind of helped create this and keep this fentanyl market. Finland also, didn't get heroin back. They got buprenorphine, but their connections, as I understand, was like with Southern Europe, with some organized crimes group from there who kind of created this demand for buprenorphine. But ours, it was fentanyl. There's, I think, just some things that happen that cannot be explained by rather than just chance or things being in the right spot at the right time. So this Estonia, we were in a sad spot. I think we got the short straw, as you say.
Yes. One follow-up question also. I wonder if I may perseverate. You talk about stigma, and I know it's very common now to try to use delicate language and try to destigmatize substance use disorders. But one of the big problems that is rarely mentioned in any discussions about treatment and motivation to treatment is based on our national surveys on drug use and health, which are done annually. And for the past 20 years and probably earlier, what we find is that 95% of people do not feel they need treatment and do not want treatment. Now, if one destigmatizes substance use disorders, could the consequence be that one becomes even more refractory to treatment?
Does anyone want to answer that? It's just, looking at the stars and predicting what happened. I don't have an answer for that, to be honest. I guess it's also not only stigma by service providers or people who are working with people who use drugs. It's just a general understanding. We see it with mental health issues in Estonia. It's been, being a post-Soviet country, you can see that men's health is something that you don't talk about. Mental health is something you kind of you just deal with it. You don't go to your psychiatrist or psychologist only if you are in deep depression already. So it's not considered as a norm in general population as well. And now with COVID and with the big talks about it, you can see people starting to address it more, being more proactive, going to psychologists and just talking about the things that they have going on. There's a shift in that, but there's a lot of focus also on a greater level to it. But it never has happened to drug policy. I don't know how it's in other countries, but this is an Estonian case. So I guess when, in a way, we could normalize being a problematic drug user or being addicted to drugs, and not normalizing the use of drugs at the same time amongst young people, for instance. I don't know how it's possible, but this is, I think, the key, that we're trying to find the balance there, because there is always a chance if we talk about something too much, people have a feeling that it's a very popular thing. This is what happens when you go to talk to school in schools about drugs. It normalizes. So yeah.
Okay, thank you. We have got some questions also on the mail, but we will answer that in the program or in the organization's website. But Ain, thank you very much, and I do believe that during the dinner there, I see some of the reactions here. People would like to talk to you more. So eat this before so you don't have it during the dinner. Thank you very much. Thank you.